Therefore, today diabetic macular edema is classified into two basic types. One is what we call a center-sparing diabetic macular edema, and the second is what we call a center-involving diabetic macular edema. So I'm going to talk on what is center-involving diabetic macular edema. So what is center-involving diabetic macular edema? When you find that the center of the macula is involved, you can see here the central macular thickness 380, and if you see the OCT, you see a diffuse edema which is there in the center with a very early cystoid change and some degree of spongiform edema. Therefore, this is what we call as a center-involving diabetic macular edema. Now, this could be of two types. One is focal and diffuse based on the fluorescein angiogram. Now, basically, the randomized trials, all the patients that were included in the RCT trials had a visual acuity of 20/40 or worse. And there is no information, as far as the RCT trials are concerned, about patients with very good visual acuity. That is, if you have a patient with a near normal visual acuity like 6/9 or 6/6 partial who comes into your clinic with mild distortion of vision, and he says he is not able to read very clearly. So this is what is known as the clinical scenario 1, where you have a patient with good visual acuity, with mild CSME. What do we do? Should we treat or should we observe? So basically, there are two categories here. One is you need to treat these patients. The patient is grossly symptomatic. For example, I had an architect who had a similar situation where just 6/9, 6/6 partial with mild CSME, but then he said he is not able to do his work. Now, this is a situation where probably we need to initiate treatment. But the patient is not very symptomatic. Patient is able to continue his day-to-day work. Probably you can observe such a patient, follow them up very carefully with OCT, and if the patient is worsening with time, probably we can initiate treatment. So I can show you a small case here, one of my patients with a history of diabetes of 20 years duration. And if you see here, the right eye, he's got a few drusen. Apart from that, he's got a few microaneurysms and hard exudates. And if you see, the left eye is absolutely normal, except for very fine microaneurysms here, very early maculopathy. And if you see the OCT of the right eye, he's got very early cystoid changes in the macula. Now, he's got a vision of about 6/9 and 6 nearly. So this is a situation where you are really debatable whether you want to treat or not. Now, after a chat with the patient felt that he would like to wait. So this patient was followed up every 3 to 4 months. Between 2014 and December, 1.5 years, he was followed up. And you can see here with a serial follow-up, there is a slight worsening in the middle, but finally, over a period of time, with just good diabetic control, the macular edema is completely resolved, and he is having near normal vision without any intervention. Therefore, my very mild case of CSME with very good visual acuity, where the patient is not grossly symptomatic, you may follow up these patients for some period of time, and you need to intervene only if they worsen. This is the left eye, which is normal. Now, clinical scenario 2 is a patient with a center-involving diabetic macular edema with moderate visual loss. Now, this again is a case of a lady, a doctor actually, with a visual acuity of about 6/18, 6/12. In a workup of the patients, initially we need to do both the fluorescein angiography and the OCT. And the fluorescein angiography tells us what type of edema it is. Now, here you can see a lot of microaneurysms. And you also see the foveal avascular zone, whether the perfusion is good. This is a very important indicator as far as the visual improvement is concerned. Therefore, here you've got a patient with a lot of microaneurysms and hard exudates with a center-involving DME. And if you see the OCT, there's significant thickening. And this patient was initially treated with intravitreal anti-VEGF injections. And you can see she is a good responder. As I told you, in anti-VEGF, we can define them very early. And you can see here, immediately after treatment, there's a drop in the retinal thickening. And therefore, she is a good responder. And you see, with multiple injections, and subsequently perifoveal laser, focal laser to the microaneurysm, because she's got a lot of microaneurysms. And therefore, if they have a lot of microaneurysms, you can't give thermal laser, because our aim and objective is to see whether the number of injections can reduce. And in the DRCR protocol, they have shown that the patients with the laser group did have a slightly less number of injections when compared to the other groups. Therefore, you can see here with perifoveal laser, the retina is now flat after 3 injections and subsequently laser. I usually repeat the angiography once more, and I also treat the residual microaneurysm. So you can see here, some of these are the laser marks, but you still have a few microaneurysms here. And therefore, and since they are quite far from the center of the fovea, they're quite safe to treat, and they receive a second dose of perifoveal laser. And over a period of 2 years follow-up, there is no recurrence of the macular edema. Therefore, this is a patient who has responded well to anti-VEGF injections, who has received a combination therapy, and over a period of 4 years shows stabilization of visual acuity and also no recurrence of the diabetic macular edema. And you will see the serial photograph here, initially and final, even the hard X-rays have completely disappeared. So the last scenario is a scenario of multiple interventions. So this is a patient, last case, to show you a different scenario in a center involving DME. This is a female patient with a visual acuity of 6'9", 6'18", N12. You just have a look at one eye. Now here the fluorescein angiogram shows something like not much of microaneurysms, a lot of leakage. And if you see the OCT, there is significant edema. So this patient again was treated with multiple anti-VEGF injections, and you can see here with ranibizumab, she's a good responder. She has responded immediately with treatment. And she receives multiple injections, and she has responded with 3 doses of Lucentis and a little laser. She has responded, but then the edema is slowly coming back over a period of time. So once the injections were stopped, after the macula became normal, again there is a rebound increase in the thickness, and you can see here, again it's come back with a bang. So in this particular situation, what I did was, I injected Osurdex, because I felt that there is significant thickening, and it's recurring after anti-VEGF and laser, and I treated her with Osurdex, and along with Osurdex, I also did a fluorescein angiogram, and she had a lot of peripheral ischemia. Therefore, I gave a little bit of peripheral laser along with the Osurdex, and with that, there was a resolution, and waited for some time, and over a period of time, you can see, although there was a little recurrence, but then once the effect of the laser came in, there is no recurrence after this, and she is now under our follow-up. Therefore, this is a patient who received combinations of treatments in a patient with center involving diabetic macular edema. Thank you.